It's exciting to be here. I was watching people walk in and seeing so many faces that I know, people that I've collaborated with before, people doing good work in Alaska, and I see faces that I don't know, and I look forward to getting to know you. When I was asked to consider giving a keynote this morning, I was asked to share a bit about the tribal health system and Southcentral Foundation, and I was thinking what would make sense for this audience, this group of experts, and decided I would try to do two things. The first is tribal health is such a big part of our healthcare system in Alaska that when there's the opportunity to share a bit about what we do, I think it makes sense, right? There are folks in the room who work in tribal health, who work with tribal health, and I would imagine there's new folks that might not quite know what tribal health is about. And so I'm going to share a bit about that from SCF's perspective. As I do that, you'll hear about our values and how we conceptualize what healthcare can be. And so in the second part, I would like to consider those values, that lens, and use that as a way to think about our broader healthcare system in Alaska, just from the way that SCF thinks about what wellness and community means. So that's my two parts today. Before I talk about what SCF is doing, I'll share that when I speak, I tend to focus on philosophy and approach and values. And I find that if I do the data slide at the end, I've lost people, right? Like, that sounds lovely, what are you producing? And so I have this data slide that we do at the beginning that talks about this journey of transforming healthcare and the impacts that it has in community. Reductions in inpatient stays and ER utilization, and HEDIS measures. And I can remember at the beginning of our journey when every number you were supposed to be low on, we were high on, right? Or every number you were supposed to be high on, we were low on. And as SCF has redesigned our healthcare model, we are now hitting consistently 75th and often 90th percentiles. I remember when the goal was 50th percentile, right? Mediocre. Let's just try to hit average. And this is really exciting. And in the bottom here is this balance between customer owner satisfaction and employee satisfaction. And I think that's really important as we think about healthcare today, right? What does our system feel like to the people who come through our doors? And what does it feel like to the people who are working in our system? And I don't know if you know, I've been with SCF for 20 years. In the beginning, I was the director of HR. And so thinking about the workforce and healthcare being a place where people want to grow. And then thinking about community and self-determination and customer owner satisfaction, and how do you do both of those things at once? And I'm going to talk a little bit more about that. When I talk about the tribal health system, I can really only share SCF's perspective. And that has to do with my story being a kid growing up in Anchorage. So my family is from Ninilchik. That's where we are tribal members. Everybody here, have you driven by Ninilchik before? Beautiful, gorgeous little village. And you can see the little Russian Orthodox church on the bluff on the right. Can you guys picture that? So my great-grandfather was the priest of that church. My great-grandmother moved to Ninilchik from Kenietze. So if we had signed up with tribes a generation earlier, I would be a Kenietze tribal member. Moved to Ninilchik, raised her family there. And my dad grew up part-time Ninilchik, part-time Anchorage. So in my family's lifetime, over a few generations, we transitioned from what was largely a subsistence lifestyle to a Western cash economy. Like, I can just feel that trend. Now, my mom comes from California. She was a bit of a rebel. She was a laborer on the pipeline. That's where I get my blonde hair. And my partner, Matt, brought to our family 2 kids who are non-native. And so I experience our system through the tribal health system and through a non-native system as well. This is what the old hospital used to be in downtown Anchorage. You guys remember the old IHS hospital? Yay. When I do that, that's not very many hands. A lot of you don't remember the old Native hospital downtown. Someone described it recently as kind of a scary place. When I was a kid, it was the place that you went to when you didn't have insurance, when you couldn't afford to go somewhere else. It felt to us as a family like the second-class place to go. You knew that if you went to Providence or Humana at the time, that it would be the better hospital. And if you think about what that means for Alaska Native people, to know that their healthcare system is the second-class place to go, and you think about concepts of identity and self as drivers of wellness, you can think about the harms that that created, right, in this old hospital downtown. Amazing people working there, working very hard, in an underfunded system that had no ability to keep up with the needs of population. And everybody entered the system through the emergency department, and you just waited. And they tell me there was primary care. I believe that to be true. I think there were 5 docs, but you could never get in. It was impossible to get an appointment. I don't ever remember going to any kind of a family medicine clinic as a kid. So the Indian Health Service began because the US government had a treaty obligation to Alaska Native and American Indian people, right? And that negotiation, government-to-government negotiation between tribes and federal government, resulted in this obligation for the US government to provide health care to Alaska Native and American Indian people, and the IHS was the venue for doing that, right? That was the vehicle. And along came something in the 70s called the Indian Self-Determination Act, which said that the prolonged federal domination, of the Indian Health Service programs was actually harming communities. Rather than creating wellness, it was making us sicker. And instead of the government providing services, there was an opportunity through self-determination for Alaska Native and American Indian people to contract or compact those federal dollars and operate our own healthcare services. Anybody remember in the 70s when that was happening? Not many people. There was a few people. There was a big debate across Indian country about whether we should begin operating our own services. And there were people who said no to the federal government. You can't give us pennies on the dollar when you haven't met your treaty responsibilities and expect us to operate services with that kind of funding. Alaska was different. In Alaska, all across the state, leaders came together and said, we think we can do this better. We want to operate our own healthcare system. And the tribal health system in Alaska, I know that many of you are familiar or work in the tribal health system. It's really this amazing demonstration of what it can look like when a community has the opportunity to design something that can be meaningful to its families and its people, right? What does that look like? And the result is an actual system of healthcare, in comparison to what is often a bunch of islands of healthcare, trying to be a system, but not really organized in a way where a system can happen. So this is a picture of the Alaska Tribal Health System, and on the outside are all of the dots that represent the federally recognized tribes. And for some reason in my head at about 7 o'clock is Ninilchik. They're not actually labeled, but I can see my tribe there. And then the outside circle are the regional tribal health organizations. And you'll see one of those light blue names is Southcentral Foundation. So we're a regional tribal health organization providing services in the South Central region of the state. And our peers include, for example, at 9 o'clock, YKHC, Yukon-Kuskokwim Health Corporation, Norton Sound Health Corporation, TCC up on the far, what is that, your right, who I know is in the room. Every region has the opportunity to have local control of how they develop their own healthcare system, right? And they all look a little bit different, right? But through self-determination, local design of healthcare is able to best meet the needs of the people and communities in its area. Each of the regions has a hub community, sub-regional clinics, and village clinics. Some of them include urban healthcare, lots and lots of very small rural healthcare, as you could imagine. In addition to this regionalized system, well, let me just mention for SCF, so the South Central region of the state has 70,000 Alaska Native people, 40% of the population of Alaska Native people in the state. And as a result, we are the largest of the regional health providers. We have 2,700 employees. Exciting to say that we're adding 85 employees next year, so moderate growth, which is good. But in addition to this regionalized system, there's a need to have a statewide hospital so that all the regions can refer into that hospital for specialty and hospital care that they might not have the economies of scale to build out locally in their regions. And if you have a regionalized system and you're going to have a statewide hospital, inevitably it's going to sit in one of the regions. So the hub for the South Central region is Anchorage. The hub for the state is also Anchorage. And so the way that's organized follows a federal law called Section 325, which creates ANTHC, our partner, and allows ANTHC and Southcentral Foundation to co-operate the Alaska Native Medical Center. So part of what we do at SCF is this partnership with ANTHC at ANMC, supporting statewide services, and part of what we do is local and regional services. And we're going to talk more about what that looks like. Before I leave this slide, you'll see up on the right the Alaska Native Health Board. And the Alaska Native Health Board is the place where the whole tribal system comes together to discuss what our advocacy needs are and to advocate together. I see Alberta in the back. Hi, Alberta. And I think it's hard to understand what the tribal health system looks like. And so I love this slide. It's the best I can do in 2 minutes to say what is the whole tribal health thing before I dive into kind of how SCF operates its part. So what does SCF do? I think one of the things that is exciting is that we landed a vision that isn't just writing on a plaque on a wall, but drives how we think about doing our business. And our vision is a Native community that enjoys physical, mental, emotional, and spiritual wellness. And I want to invite you, just for a second, to think about multidimensional wellness and just sit in yourself for a sec and feel your body and notice how you're doing today physically, mentally, emotionally, and spiritually. So when we think about wellness, we think each of us are on a journey of life, and at every step in that journey, those elements of wellness are within us, and they're not separate things. They're actually connected and in balance with each other. And we can think about times in our life when our physical health struggled and it pulled down our emotional health, or times when we invested in our spiritual wellness and we saw that pay off in our physical wellness, right? And it means that if we are all balancing physical, mental, emotional, and spiritual wellness, then we design programs differently. Every program is about that multidimensional wellness. The example I like to give is dental. I have a daughter who had braces a couple years ago, and what was happening for a teenage girl with braces? Physically, teeth are moving. What was really happening for a teenage girl with braces? Do we do behavioral health in dental? Absolutely, every single day. Do we do emotional wellness in dental? Absolutely, every single day. So we design a healthcare system based on this idea that mind and body are connected, that it's not enough to say, oh, good news, we have behavioral health in that building over there for that one uncle in our family. And we create a mission, and the mission is how we get to the vision. It's the way that we do it. And the mission for us is working together with the Native community, working in partnership, shared responsibility, and working in relationship. This idea of working in relationship with community is an intentional push against what usually exists as a hierarchy in healthcare. So the hierarchy in healthcare tends to say that those of us with the big titles and all the initials behind our names know what's best and will figure out how to design healthcare, and the people who come in to receive it are in a recipient role, right? It creates this hierarchy. And we want to push against that. We want to say, what does it look like if a community owns its healthcare system and drives its healthcare system? And how do we sit in relationship between an institution and community at a macro level? And how do we sit in relationship at a micro level between a care team and a family? And we would say that that competency of sitting in relationship is in fact the product of our healthcare system at Southcentral Foundation. So what we aim to produce is not diagnosis or treatment plans or prescriptions. I know we got some pharmacy over here. What we aim to produce is the quality of relationships that we can sit in at all levels, at a macro level between institution and community, at a micro level between a primary care team or an addiction care team and a person or family, and then at all the levels in between. How does our system connect with other parts of the system, right? How do we create service level agreements and intentional passes and pull discharging so that the experience for a person going through the system makes sense from their perspective? Early on, as we were thinking about our orientation to community, at SCF we made a choice to not use the typical word that we use to describe people who come in to receive services. So in our systems, we're used to the word patient or client or member, and in our minds, that's a recipient role, and it doesn't describe how we are oriented to our community. So we use the word customer owner, and I think for us, when we choose to have a shared understanding of our orientation to community and a shared language that we use together, it allows us to achieve that future state of true community ownership, community-driven healthcare system. So if you come to work at SCF, raise your hand, we'll take down your name and try to hire you later. I'm just kidding. You will forget and you will say patient, and we will say customer owner, and hopefully that becomes natural because it really is how we are oriented with our community. We use this diagram with new employees to talk about how we can impact wellness with families. And on this diagram, on the very right-hand side, you have situations with high acuity. So in a high acuity situation, let's say I parked and I jaywalked and I got hit by the bus this morning, right? And I go to your ER and I'm unconscious. High acuity situation. The healthcare system has very high control, right? I don't want to collaborate with you about what the next step's going to be. I'm unconscious. Please save my life, right? And our healthcare system's very good at that, right? Very good at being in control. But when we think about our life journey, how much time do we spend hit by a bus unconscious in the ER? Hopefully, very little of our life. And most of our life is in all of these low acuity situations. Most of our life has to do with what we eat, what we drink, whether we exercise, how we manage stress, how well we sleep, how we parent, how we were parented, right? Those are the choices, the behaviors that happen in our real lives that impact our wellness. And in all of those situations I described, do we take the pill? Did we forget the pill? Do we cut it in half? Do we take the other pill somebody has in their purse, right? Who has control of that choice? Not the healthcare system, right? The family, the person, the individual has control. And so if we want to be part of that person's choice in that journey, right, how they parent, how they manage stress, then we need to do that by creating a relationship, by being easy to connect with, by being easy to talk with. So that when you're struggling in life and you think about where to turn, you might listen to what Oprah has to say, or call your mom or call your friend. But just as easy, you could call your healthcare system and say, hey, I'm struggling with this. Can we talk about it? And if we can be in real human relationship longitudinally over time between care teams and families, then we aim to be one of the 3 or 4 places that you turn when you struggle so that we can be part of supporting those decisions that happen in all of those low acuity situations, because that's where most of our life and most of our wellness is driven from. So to do that, we have put a bunch of investment into a primary care model where the customer, owner, and family have a longitudinal, intimate, personal relationship with 4 people. the primary care provider, CMA, RN case manager, and a case management support. The case management support is an Alaska Native person, a community member, and it's a high-level administrative function. And when I'm at home and I've got a kiddo with a fever, and it's 101, 102, 103, what do I do? I can call that CMS. I know his name. I know him by first name. He knows me by first name. And I can say, hey, this is what's going on. I think I might want to come in. And I don't call the front desk or some call room or some other place. I call the same person. And that CMS is sitting in shared space right next to the nurse case manager, right next to the physician, right next to the CMA. And depending on what I'm asking for, can just say, hold on a sec, April, and can ask the nurse, what do you think, right? It's a med refill. I can tell you that you have a refill available to you. Or why don't I catch the doc when he's in between appointments and ask him if he can write that script, or do we need to have you come in for an appointment? And that happens through relationship that we develop over time. An example of that is my primary care provider took time off and went and did a marathon. And I know about him. We've been in relationship. I was excited for him. But something happened with my kiddo, and we were in the ER 2 or 3 times while he was gone. When he came back, he called me and said, whoa, April, I don't ever see this, that you're in the ER that much. What's going on for you? How are you doing? So around that primary care team, which is supporting about 1,300 customer owners, you have integrated services like a master's level behavioral health clinician, pharmacist, dietitian, midwife, and then still in primary care in the darker circle are a set of specialists. All of those people can be pulled into that primary care relationship at any point in time. And the idea is to maximize the relationship so that you don't tell someone, oh, you should really talk to a dietitian, let me refer you there. Because what happens when we refer people there? How often do they make it? Some percentage of the time. And when they go, it's a new person they're sharing their story with, and do they really tell you that they eat McDonald's every day on the way to work? Right? You're not going to really say that when you first meet somebody, but maybe when you're really in a relationship and you're talking about the things that matter in your family, you can start to be honest with each other. One of my favorite examples is my primary care provider was at an appointment, opened the door and said, April, I know I'm running late. I have somebody else that's kind of in crisis. I just have to. And he was stressed at the idea of being late for this appointment with me. And what did I think? I got your back. We're just fine. It's okay. Go and be with somebody who needs you right now. That's relationship, right, between customer, owner, and provider. On the outside of the circle, we have some of, but not all of, the type of specialty that we can refer to. We play in the tension of how much to keep in primary care relationship and when we really need to refer to specialists. And I'll just share the psych team as an example. We have an integrated team of psychiatrists who work in primary care, and they are able to be pulled into visits or do case consults with primary care providers, but they don't deliver any direct care. And by doing that, what we found is that the primary care providers are way more comfortable maintaining relationship and maintaining care for people with behavioral health needs when they have a colleague in the office who they can chat with, right? About, gosh, these 2 or 3 depression meds that I'm comfortable with don't seem to be working. Should I refer out or try something in primary care? How do we keep the relationship in primary care? And that doesn't always work. Of course, we have specialty psychiatry that we refer to as well. This is just a picture of how people sit all together. We have no doctor's lounges. We have no nursing stations. We ask people to work collaboratively in integrated care teams. And we're expecting there to be a different role for the provider. Not a hero, not an expert, doesn't have to know everything. And a different role for our customer owners. Not a recipient, not waiting to be told, but both are active parts of a relationship and partnership, each bringing expertise, right? So medical provider brings all of their education and expertise, and guess what? Niece, daughter, mother, father brings all of their expertise too. And if we can do that through honest relationships, then we can start to impact all of the choices that happen in our life in our low acuity situations. When you start getting in real relationship with families and seeking to understand what matters to them, One of the most frustrating things is when you discover there's really something there, addiction or domestic violence or something hard that you know you don't have the time to help somebody with today. And so we need a continuum of services with easy referrals that are built at population size, and SCF has invested in that. And I think you guys know, this is kind of I'm supposed to be about everything SCF, but I love behavioral health. I mourned behavioral health when I left that division to become CEO. And I will tell you two things. One, while we have 550 people in our behavioral services division delivering specialty behavioral health care, and while I am excited about the services that the people who are in those programs receive, I know we have not invested as a system, as a state, as a nation, in really having all of the services that people need, really having the continuum, having earlier interventions, having interventions locally in people's communities, so that when somebody says, I need help, 100% of the time we can say, yes, we have that service. We have to keep building this. This is our fastest growing division. And then we have a bunch of specialty services that we look to create access and population size for. We've done a lot of work around data, so I will say, I don't know if there's any EHR folks in the room, but EHRs are largely built to tell your payers that what you did counted as healthcare and that you should be reimbursed. They're not particularly good at thinking about wellness or population health. And so what we did early on is created a data mall that holds all of our data above our EHRs, and then worked to change the way we think about data so that instead of it being a quarterly after the fact judge how you did, we decide on the measures for the organization and the dashboards for the individual care teams, and we put that data in the hands of those care teams in real time. So that if you know that you're aiming to improve mammography or vaccinations, that you can click on that and get the names and phone numbers of the people on your panel who you can reach out to bring in for those visits. And it's moving past the idea that our job in healthcare is just to react to the people who come in, but rather to be responsible for the outcomes for a specific population or group of people. And that's what your job is to be tasked with. It's equally as important as the people who happen to call today to say, I need healthcare. I got 2 more slides on this. Lots and lots of listening to community. If we're going to be driven by community, how do we listen to community? And we're playing with the idea that in the old healthcare model, healthcare experts would meet a patient for 15 minutes and know what you should do and tell you, here's your direction, and then later judge whether or not you're compliant, right? Old way of thinking. New way of thinking. Who knows best what families need? Who knows best what matters to families? Families do, right? How do we create the way for community to tell us what they need our healthcare system to be, and then innovate based on that direction? And then go back to community and say, here's what we heard from you. Did we get it right? And allow community to judge us as to whether or not we, their healthcare system, are compliant with following their direction. That's the aim that we have at Southcentral Foundation as we interact with our community. I talk a lot about SCF, and I get excited about our journey. I get excited about this integrated care team model, but I often don't say, as clearly as I should, how much work there is ahead of us. We did a big needs assessment early on in our journey, and we did it again right before COVID. We asked community, what are your top 5 needs? And community spoke loud and clear. Continues to be addiction, but added obesity to the list. Continues to be domestic violence, but added cardiovascular health and dental. So those community needs drive what we're looking to invest in today. We're working on things like aging well. How do we support our population as we are getting older? Aging Well initiative has all of this touch points, and it begins at age 40. When they brought that to me, I said, wait a second, that's my bracket? How do you consider that to be elder? And they said, that's when you got to start thinking about how your body is changing. It's also when you start transitioning your relationship with your parents, right? And how they are doing. So 40 is where Aging Well starts. We have a new initiative called New Generations. thinking about how much new parents want to make all the changes they can for the wellness of their child, and recognizing how did we learn to parent from our parents, right? So how can we walk with these new families to provide competency around early child development and early child mental health, and identify when the real need for that family might be an addiction treatment service? And how do we wrap around those families at a very young age? Lots and lots of work to do around suicide prevention, around building out access to services for children with developmental needs, earlier interventions for youth mental health services. The list is long. So I'm going to transition now from what is SCF doing, how do we think about healthcare, and try to use these values, this lens, to think about all of us collectively. So we are all people who either deliver healthcare services or support the delivery of healthcare services. We're leaders in this industry. And my very favorite thing about Alaska, and I say this all the time, is that we are largely a collaborative market. I'm going to California and giving a keynote next week. Much less collaborative market, lots of competition, right? But we are largely a collaborative market. We know each other. Look at the size of us. We're small, we're large. Who said this morning we're a huge little state? Somebody said that to me. We're a huge little state. And we have some places where we're competing, right? That happens a little bit. But I think deep down, none of us are trying to build an empire, right? Or to win. We're trying to figure out how we develop services that are meaningful to Alaskans. And this, I think, is one of our most natural and strongest competencies as an Alaska healthcare system. We are small enough that we can be in relationship with each other. We can grab coffee with our commissioner. We can fly to Juneau and chat with legislators who, in 2 days you can meet with 8 or 10 who are all thinking about a vote on a topic that matters in healthcare. And we can reach out to each other and think about how we're expanding services, what we see the need as, and collaborate, right? It would matter to me to know what somebody else is doing. It would impact what I think we might do at Southcentral Foundation. Relationships are really easy when we agree with each other. So if we look around this room right now, notice our colleagues who are here. We all have friends, right? People who we know, if we said, can you believe that? We really have to work on this. They would be like-minded, right? They have a mission that aligns with our own mission. We're collaborative. And you're probably sitting at the table with those people. But relationships are even more important when we disagree. So when we disagree, that's our chance to be curious about why somebody else has a different opinion than us, to wonder what data or experience leads them to hold that position. When somebody has a different opinion from us, we can either avoid them or we can choose to share more about why we hold our position, right? What drives us to advocate in that way? And maybe the slice that I know and the slice that you know are different, and I'll change my view based on what you think, how you think about it. And we have the chance to build the type of relationship so that we can have that healthy exchange of different ideas. We do that, right? And not just with the people that we're naturally in relationship, we do it with each other. And I love when someone else has a different opinion, and I really feel like I value that their opinion can be valid, even though it's different than mine. And I can ask, what does that mean? What does that look like? We have this thing at SCF called Core Concepts. It's a 3-day training that's about this competency of being in relationship. It's about ladder of inference and mental models and relational styles. And at its heart, it's about story and how we build relationships when we share a piece of our heart with someone else and they share a piece of their heart with us. And this idea of being in relationship is so important to me that there's a team of us who do this 3-day training. We're doing it 11 times this year with groups of 100 employees each time. So as a CEO, I'm spending 33 days in this competency development around relationship with groups of employees because I think it's that important. It's the how we get to what we get to. And so the last thing I want to say is I thought about, should I use this time to speak about the issue, like to convince you of my opinion about what we should do, right? Around changing how we're paid or changing what we contract out or how we should approach workforce. And I decided that I'm not the expert in any of those things. The panels you're going to go to are going to be made up of those experts, all of you around this room. And you'll get to dive into specific topics. And more important than any one topic that we might have today, to me, is the quality of relationships that we can sit in with each other. And there's this analogy that I use, and you may have heard it before, where we were trying to think about how to do a service differently. And it happened to be outpatient addiction treatment services a number of years ago. And what we found is that even though we were hearing from our community about what they needed, and we wanted that to drive our clinical service delivery model, the voices up here were louder. How we're paid, how we're regulated, how we're accredited, what our grantors think we should do. Those were the louder voices pushing us to organize our services in a way that checked all their boxes. But our community was telling us, starting with a multi-hour long assessment is not the way you begin relationship, right? So what do we do with that? And we decided in this planning session that I, as the leader, would hold all of that, regulation and law and accreditation and grantors up here. I'll hold it. And let's just brainstorm what would work for a community. And if the right thing to do is build a canoe, and I don't mean like figuratively, I mean literally, bring people together and build a canoe in the woods. If that's the right thing to do, then let's do it. And as leaders, let's look and say, okay, well, can we figure out how that can be reimbursed by Medicaid? And does it check the boxes for accreditation? And, how do we convince, I'm gonna follow the law, okay, just to be clear. I'm not saying I'm not following the law. But can we check all the boxes and still build the canoe? And if we can't, then that's where reform and advocacy comes in. Then we invest in the demonstration project to prove that it's effective. And then we go to all of you and say, we think this is a good idea, what do you think? We talk to our associations, we go to Juneau, and we change, right? We change all of the things that drive us based on what we know will work for a community. And I think that is at the heart of everything that we're going to talk about for the rest of the day. So I'm just going to end with this. I know that I am just one person, and all of you are experts, and each of you could share something valuable with the rest of us today. But I just really appreciate that in our state, we welcome tribal health to come on stage and share from their perspective what healthcare can look like. So thank you for giving me time this morning.